And my whole family is like, my dad was all disappointed.
Oh shit, for me.
Yeah. I just don't like the thick fluids that
Was that you want to type? Say again?
Can you see what I typed?
Oh, you're typing the post? Yeah, I saw that. I think it's cool, ladies.
They know it's hungry. I think we should. It's kind of like if it wasn't. Got it? My practice amp. Really? What's it? Mine had that. That's all. I already did my denture pop, and I can't do my x-ray because I don't have any x-rays that are eligible. I wonder if I'm going to do well, I'm going to do my brother's x-rays next week, so I'll just get that done like after all my holiday vacation. Yeah, be careful with that one. That makes like about half a I literally had this like
There you go, alright. I got a cigarette.
6mm pocket in the back. So I'm all right. I just read it before I did it. I mean, my experience in our life. So I could do like Good morning. Today. Oh, damn it. So you're going?
I guess, but she said that it's okay if not everyone can come, because I guess they're gonna have multiple like meetings.
Yeah.
I don't even know where it is.
Can you guys hear me? And we know there's not going to be no food, so.
Okay, we'll go ahead and get started. So we're going to continue our topic from Monday. We're talking about skin diseases in the mouth. So there were a few topics that we touched upon. One of them was pemphigus vulgaris, and then we talked about mucous membrane pemphigoid, and then we stopped at erythema multiforme. And when we started talking about erythema multiforme, I talked to you guys about how the classification scheme has changed. They used to have 4 entities included under erythema multiforme, but now, they just have 2 entities under the classification. So it's erythema multiforme minor and major. So these 2 entities in the old literature actually used to be considered a variation of erythema multiforme, Stevens-Johnson syndrome and toxic epidermal necrolysis. But now they've separated them, so they are considered, independent. So Stevens-Johnson syndrome is considered a variation of toxic epidermal necrolysis. What is the difference is basically the extent of skin involvement, between erythema multiforme and Stevens-Johnson syndrome or toxic epidermal necrolysis, because they can also be seen secondary to medications, just like EM, these conditions. Okay, so what happens in these patients is when you diagnose them with either SJS or TEN, there's a significant sloughing of the skin in these patients. Okay, and if the amount of sloughing involves less than 10% of the body surface, then you call it Stevens-Johnson syndrome. If it's greater than 30% of the body surface, it's called toxic epidermal necrolysis. If it falls in between, they don't have a name. Okay, but basically, I would say anything under 30% would be Stevens-Johnson syndrome. But for your quizzes and exams, you have to use the distinction is if it's less than 10%, it's Stevens-Johnson syndrome. If it's greater than 30%, it's toxic epidermal necrolysis. So this area of the skin that's affected actually shows significant sloughing. It almost looks like if someone has been burnt, how the skin sloughs. That's the similar clinical presentation that you see with these 2 conditions. Okay, so when you have patients that present with this is not something we end up treating, right? So you have to appropriately refer them to a physician. The likely possibility of you seeing them in your clinical practice is very remote, but you may see them after they've been treated, because they're going to have complications because there's such a significant sloughing. Sometimes it can cause limited mouth opening for these patients because there's, when they heal with scarring. And then that could, cause limited mouth opening. So that could be something you may encounter as a complication from patients who have had this disease, who have healed, but then come to you, for treatment.
We're going to see some pictures of that?
Yes, I'll show you some pictures. So basically, as I said, these patients can also have eye damage, just like you would see in erythema multiforme. Remember erythema multiforme major? We said they can have eye involvement, and the eye lesions usually heal with scarring, similar to pemphigoid, mucous membrane pemphigoid. Okay, so this is the kind of involvement you can see with these patients, where they have significant sloughing of not just the oral mucosa, but you would see a similar presentation on the skin, as if they've been burnt. Okay, so the extent of involvement is pretty significant for these patients. So only if it involves about 10% of the body surface, you have to make this diagnosis. Okay. And basically, SJS and TEN are also seen secondary to medications. Okay, so remember EM, what were the 4 things we talked about that could potentially be a predisposing factor for erythema multiforme? Do you guys remember from Monday? So it was antibiotics, analgesics, herpes, or mycoplasma pneumoniae. Those are infections or medications two categories, and there are four things under two categories that can precede an erythema multiforme, right? Whereas with Stevens-Johnson syndrome and toxic epidermal necrolysis, it usually tends to be medications, not infections. Okay. So when they get eye lesions, as I said, 50% of the patients can develop eye lesions, so they can develop significant scarring of the tissue, of the mucosa, the conjunctival mucosa. Okay, and then eventually they can go blind. Okay, so this is important to address. So again, this is not something that we treat in our clinical practices. We have to send them to a physician. They have to make sure that the patient, if there is a medication that has triggered this process, then they have to remove that drug, from basically prevent the patient from taking that medication. These patients will have difficulty eating and swallowing, so they are going to be dehydrated, just like erythema multiforme, because of the extent of involvement. So they have to be given IV fluids. Okay, so they are hospitalized, these patients, for the most part. Sometimes they also treat them with corticosteroid therapy, but that's a bit controversial, whether to treat it with corticosteroids or not. Okay. Yes?
So the lips picture you showed us, it's for both of them, correct? It's
Yes.
just the difference of 10% or 30%.
Exactly, yeah. If 10% of the skin surface is involved, apart from other mucosal lesions, then you call it Stevens-Johnson syndrome. If more than 30% is involved, then you call it toxic epidermal necrolysis. So obviously, if someone has Stevens-Johnson syndrome, the extent of involvement is not as severe, right? So the mortality rate that's associated with this is going to be lesser compared to toxic epidermal necrolysis. So the number of patients who can die from this disease is about 5% in Stevens-Johnson syndrome, whereas in toxic epidermal necrolysis, it goes up to 30%. So that's a significant percentage of patients affected by the disease that can actually die from the disease. So early recognition is important, and then making sure that this patient sees a physician ASAP is important, because the treatment has to be initiated right away, and that triggering factor has to be removed right away. Yes?
Do you have pictures side by side of Stevens-Johnson's and then toxic epidermal?
Unfortunately, I don't, because I haven't seen one in my clinical practice yet. But there may be some examples in the textbooks that you might be able to use. There are two textbooks that are listed on your course syllabus. Just go ahead, view them, and I'll see if I can find something and add it to the PDF document. When I upload the PowerPoint PDF, I'll find some pictures that we can upload. Okay, so this entity is something that I want you to pay attention to, because this is something you will encounter in your clinical practice. This is a disease called lichen planus. Okay, so there are three entities that that I'm going to cover in skin diseases that are important for you guys. One is lichen planus. The other one is mucous membrane pemphigoid, and then the last one is pemphigus vulgaris, that are immune-mediated diseases that can look very similar to each other, and it's important to differentiate them, because the treatment, there may be a subtle difference in treatment, but the impact that it has on the patient is significantly different. So if it's mucous membrane pemphigoid, remember we talked about how they can affect the eyes, and the patient can go blind. Pemphigus vulgaris, we said it's a life-threatening disease, because if it's not recognized early enough, it can affect significant portion of the mucosal surfaces and the skin and can kill the patient. Lichen planus does not do that. Okay, so this behaves a little less aggressively compared to like pemphigus vulgaris, or this doesn't cause blindness like mucous membrane pemphigoid. But this is important to know because it mimics the other two diseases. Okay, so what do you guys see here in these clinical pictures?
Like shredding of the mucosa, the vocal area.
If I can get this to go. Okay, so let's start with this picture.
Really red. Redness, inflamed.
So there's, what is inflamed? What is red?
No.
Marginal gingiva. Is it, you have to say marginal facial gingiva, right? Because if I did not see this patient, but I come and read your note, I need to be able to visualize exactly where the lesions are. So when you guys write your SOAP notes, it's critical to indicate where exactly you're seeing these lesions. So basically you're seeing this erythematous inflamed appearance of the gingiva affecting the marginal facial gingiva, right, on the maxilla. Okay, so is this localized to one area or is this diffuse? Diffuse, right? So it's involving a significant portion. Pretty much all of the teeth, the gingiva in relation to that is affected. How about this one? Very similar, right, to the other one. So you have very similar presentation. This patient also has some, loss of interdental papillae, but that's not the area that we're focusing on. We're looking at basically the erythematous gingiva. But what's happening here on the buccal mucosa? What do you guys see here? Don't give me a diagnosis. I want you to describe for me.
White.
So you have white lesions. They appear to be diffuse. What area of the mouth is affected? Buccal mucosa. Is it unilateral or bilateral? Bilateral. Okay. And then is there some kind of a pattern to the white lesions? Do they look like a plaque or do they look like lines? Okay, some areas, so this area on the top looks like a plaque, but these look more like lines, right? That are kind of, crisscrossing each other, okay? So all of this is actually seen in this condition called lichen planus. So they can have two different presentations. One is called erosive lichen planus, and the other one is called reticular lichen planus. So when you see these white lesions that look like lines, okay, so linear striations that basically kind of overlap each other, okay, forming a network like a lattice, this is called reticular lichen planus kind of pattern. When you see that, that's erosive lichen planus. Okay, so that's desquamative gingivitis is the term that you use to describe that. Because erosive, the upper layer of the mucosa is actually eroded here, right? So it's erosive lichen planus. But I'll show you other examples on the buccal mucosa where it's more representative of the erosive pattern. So you're seeing reticular pattern, you're seeing desquamative gingivitis, okay? And when you see desquamative gingivitis, what were the other things that I asked you to remember in your differential diagnosis? Mucous membrane pemphigoid, pemphigus vulgaris. Remember, those two entities can also have desquamative gingivitis. So when you see this kind of a pattern, and you see this either in your patient or a quiz or an exam, and if I ask you what is your descriptive term that you're going to use to describe the appearance, you're going to say desquamative gingivitis. And if I ask you, give me your differential diagnosis, for this kind of presentation, the desquamative gingivitis, you tell me mucous membrane pemphigoid, pemphigus vulgaris, or erosive lichen planus. Okay, because all three diseases can present with desquamative gingivitis. So desquamative gingivitis is just a description. It is not a diagnosis. Whereas if you ask for a specific diagnosis, you have to give the disease names. Okay, yes? Sure. So desquamative gingivitis is a clinical descriptive term to describe the appearance of the lesions that you see on the gingiva. So when you see this erythematous, inflamed, red, diffuse appearance of the gingiva, and if you are asked to describe it, you call it desquamative gingivitis. But if you're asked to give a diagnosis or a differential diagnosis, then you have to think of three entities: mucous membrane pemphigoid, pemphigus vulgaris, and erosive lichen planus. Those are three common diseases, skin diseases, that can present with desquamative gingivitis in the mouth. Make sense? Okay. So there's many other conditions that can mimic this reticular lichen planus or the erosive lichen planus. As we go along, I'll talk about some of the things that can mimic it. Did Dr. Richards talk about lichenoid mucositis with you guys and allergies and immunologic diseases? Lichenoid reaction to amalgam? Okay. Sometimes you can see a very similar response right adjacent to an amalgam restoration. So if a patient has a silver filling, right, and then if you see the mucosa adjacent to that, sometimes you can see this reticular kind of pattern right adjacent to a restoration. So this is called lichenoid reaction to the dental amalgam, okay? It's actually not really lichen planus, but it's a response to the restoration that is mimicking lichen planus. And that's why we call it lichenoid, because it's mimicking lichen planus.
Do they really look alike? Because the one that I saw, they were like white, but they have like white dots.
Yes, so they can look very similar to lichen planus, but the difference is lichen planus usually tends to be symmetrical and bilateral. Whereas if it's secondary to an amalgam restoration, it's going to be just localized to the area where you have the restoration. You're not going to have a diffuse presentation. Okay. So, and lichen planus, as I said, it's a common disease. It affects 1% of the it affects 0.1 to 2.2% of the population actually has oral lesions, and 1% of population affected actually has skin lesions. So skin and oral mucosal lesions are pretty common to see with lichen planus. Okay, and I'll show you some examples of skin, what the lesions look like. So when you have a patient and you're suspecting that they have lichen planus, one of the things you want to ask in the history is, do you have skin lesions? And are the skin lesions itchy? Okay, do you have red lesions, purple lesions that are really itchy on your skin? The other location is oral mucosa. One more location is genital. Okay, so again, you want to check if they have skin, oral, or genital lesions. Okay, the skin lesions are the only ones that are itchy typically. Genital may or may not be itchy. Oral are never itchy. Okay, so they don't have that sensation of scratching the surface in the oral cavity. But if it's on the skin, yes, they do have that. So that's something you want to make a correlation. This is a chronic disease. So unfortunately, there's no cure for this disease. You only treat it whenever they have an outbreak. Okay, so this is something they're going to have for the rest of their lives, this condition. Okay, it's, as I said, it's relatively common. It's immune mediated. It's a chronic disease. We don't know exactly why someone gets lichen planus. Some of the theories that are floating around is maybe it's related to stress. But again, that hasn't been established really well, that correlation. And there's some theories about this being associated with hepatitis C. So, and I've seen a few cases where patients have hep C and then they also have lichen planus. But are they causative? We don't know yet. Okay, but there is definitely a correlation that has been looked at between hepatitis C and lichen planus. Yes?
So you're not saying that hepatitis C
Causes the disease.
Right. Okay.
Yep. It could be associated with it, but does it cause the disease? We don't know. Okay. Again, these are some more examples of lichen planus, and this is that lattice-like network. If you see here, we've got these white lines, and they're kind of crisscrossing each other, and then they're forming a network of these white lesions. But then whenever you see lichen planus on the tongue, it usually doesn't have this kind of lattice-like network. When you see it on the inside of the cheeks, on the inside of the lips, they tend to have more of this appearance, the reticular type of lichen planus. But when you see it on the tongue, it tends to look more plaque-like. Okay, so it's just a diffuse plaque. It doesn't have this characteristic presentation. When you see this presentation, there's a term that's used to describe it. It's called wichum striae. Okay, I don't know if it's in your handout. W-I-C-K-H-A-N, wichum striations. Okay, so that's basically this pattern is what we describe it. If you see the example on the tongue on the upper right, you can see the one on the dorsal tongue looks more plaque-like. Okay, but the one towards the ventral tongue, lateral tongue, there's again it looks a little bit more plaque-like, but it also has those line-like striations, right? But if you see the one on the right buccal mucosa, what kind of appearance do you see there? Does it look all white? No. What's different about that? I'm sorry? It's red, right? So it looks like it's red in the center, and then it has these white lines, white areas around it. So that's how an erosive lichen planus can appear on a buccal mucosa or a labial mucosa. If it's on the gingiva, it looks like desquamative gingivitis. But if it's on a mucosal surface, like buccal mucosa, labial mucosa, it's going to look like a central red area surrounded by white striations or like a white plaque around it. Okay. Again, this is a disease that affects women more commonly. It affects middle-aged women. And on the skin, they tend to look either purple or red, and they're really itchy. So there's the way it's described, it's called 4 Ps. So they're purple, they're pruritic, that means they're itchy. They're polygonal, so the shape is polygonal, and it's a papule. So that means it's not a flat lesion, but it's a slightly raised lesion when you compare to the adjacent surface. Okay, so 4 Ps: purple, pruritic, polygonal, papule. So this one looks a little bit more red, not purple. But you see that if you look at the surface of it, it's slightly elevated compared to the adjacent skin surface. And they get extremely itchy for patients. Okay? And then they can have this diffuse presentation on the skin. But remember, not every patient with lichen planus is going to have skin lesions. They may or may not have them. So it's a good idea to, question them, when you're taking the history. Do they have skin lesions, yes or no? Okay, they can have them independently. Some can have just skin lesions without oral, and some can have just oral lesions without skin involvement. Okay. Again, these are examples of the desquamative gingivitis. Here you can see how it looks really red, inflamed. It looks like the superficial layer is actually peeling off. But here, there's a slight difference. What do you guys see here? The striations, right? Yes, so you have a background of redness, but on top of the redness, you actually have those white striations. So that, if you see, you have to think more of lichen planus, right? So if you saw that appearance, would you think of mucous membrane pemphigoid or pemphigus vulgaris on the top of your differential? Not as much. You pull them low in your differential, right? And then you basically move your lichen planus higher up in your differential. Okay? So whenever you do a differential diagnosis, the way you organize your differential is you have to look at what else is available, the information. So all desquamative gingivitis, you give the 3 differentials. But then you look for other features and say, okay, what other features are here that helps me reorganize my differential and put one entity over another, okay, higher up. So this is something that needs to be biopsied. So anytime you see these ulcerative lesions in the mouth, even though clinically it mimics a lichen planus, you want to be 100% sure. So you have to do a biopsy. When you do a biopsy, what you see is basically an epithelial layer, okay, just like this here. Okay, that's the epithelium, that's the connective tissue. And if you look at the interface between the epithelium and the connective tissue, if you look at the reader ridges, and I'll show you, see if I can put my arrow there. Okay, so if you see right there, these are called reader ridges. These, they become really long and pointed in lichen planus. And then you get this blue cells right here. All these blue cells are lymphocytes. So these lymphocytes, almost like a band, they go and attack this basal layer of the epithelium. So you'll see a band of lymphocytes right underneath the basal layer of the epithelium. And then the cells at the bottom of this epithelial layer, they start undergoing degeneration. And then they start looking more sawtooth-like, the ridges. Okay, so how do we treat it? If it's a reticular lichen planus, so if all the patient has is those white striated lesions, you don't have to treat it. Okay, if they're not symptomatic and if it's not bothering them, you just make them aware of that disease process and tell them it may take 2 or 3 weeks for it to go away, but it's going to come back. Okay, sometimes these lichenoid lesions can get super infected with yeast infection, with candida. Okay, so if you do see that, then you have to make sure you treat those patients with antifungals. Okay, and then these patients have to be followed up, right, once a year at least. But however, if you see erosive lichen planus, so that means you have these red lesions, then you have to treat them because they're usually symptomatic for patients. Most patients complain of burning sensation when they eat something spicy or acidic when they have these erosive lesions. So the best way to treat it is with topical steroids. So what the oral pathologist or the dentist or surgeon, whoever, is going to basically prescribe them, the topical steroids and then ask the patient to apply on the areas that are affected. And they do that for 2 weeks and it usually helps resolve those lesions. But then you have to advise the patient that they're going to come back, these lesions. Okay, it's not something that goes away. These are some examples of different topical steroids. So you just fluocinamide, dexamethasone, there's just different products that are available with different strengths. If they do have gingival lesions, you always have to make sure that these patients get good oral hygiene instructions. You have to make sure that they're on a recall for cleaning more periodically than someone who doesn't have this disease process. Because if the gingiva is inflamed, then the likely possibility of these lesions not healing as quickly as they should is going to be higher. Okay, so you have to put them on periodic recalls for, yes?
So, are we going to need to be able to differentiate between the erosive and the reticular lichen planus?
Yes.
So what would be the main characteristic to differentiate those two? Like the main thing, the first thing that you should check if you're confused between those two.
You cannot get confused. The reason why is because reticular lichen planus will never have red in it. It's always going to be white lesions. If it's erosive lichen planus, you're going to have red areas surrounded by white. So reticular and erosive will look completely different from each other. So when you do see them, you should be specific about what type you're seeing. Okay, whether it's erosive lichen planus or reticular lichen planus.
And you said the erosive is red surrounded by white.
So yeah, erosive usually, if it's on a mucosal surface like buccal mucosa or labial mucosa, you'll have an area of central red surrounded by white striations. But if it's on the gingiva, erosive lichen planus presents as desquamative gingivitis. Reticular lichen planus basically looks like white lines. Okay, but if it's on the tongue, it can look more plaque-like. So that's your presentation typically with reticular and erosive lichen planus. With erosive lichen planus, if you look at the literature, they talk about this a 1% chance of these erosive lichen planus lesions actually transforming into cancer. Okay, so you need to make your patients aware of that there is a slight risk, and the risk is only about 1%. That's why these patients need to be on periodic recalls, much more than reticular lichen planus. So you have to bring them once every 3 to 6 months to reassess these areas and make sure that they're not worsening, right? But if it's reticular lichen planus, you can do an evaluation once a year, to make to see how it's being controlled. So that patients need to be aware of that. Yes.
Can it turn from reticular to erosive?
Typically, it can be associated. Those two can go together, but they usually don't transform into one another. Yeah. So, this entity, again, the likely possibility of you seeing this in your clinical practice is going to be pretty low. Okay, graft versus host disease. The reason why it's included is basically the lesions in graft versus host disease. They can mimic lichen planus. Remember, I said there's many things that can look like lichen planus in a patient's mouth. One of them obviously being lichen planus. The other thing would be a lichenoid reaction to an amalgam restoration. And graft versus host disease, patients who have this process can also have oral lesions that can look like lichen planus. Okay, so what is graft versus host disease? So basically, this is seen when someone is getting a bone marrow transplant, okay, to treat an underlying disease like leukemia, okay. So when they get a bone marrow transplant, what happens is if there is an interaction between the donor cells, okay, and the recipient cells, but they have different antigens, okay. So there's a cross-reactivity. They're not, adjusting to each other, right? So then the body rejects it. So that's how they end up getting this graft versus host disease. Okay, so what do you see here?
White and there's
Diffuse white lesions. What part of the mouth? The palate, hard palate, and going towards a soft palate, right? Okay. And is it bilateral? Yep, it's on both sides. And then does it have a specific pattern to it? So here it looks like plaque right there, and here it looks more like those striations, right? That are crisscrossing each other. On the tongue, it looks more plaque-like. So when you see this, without a good history, it's hard to tell if this is lichen planus, the reticular type, or if it's graft versus host disease. So it's really important to take a good history when you see these patients. Find out if they had a prior diagnosis of leukemia, or some other malignant disease that was treated with a bone marrow transplant. And if they did have a transplant, how did the body respond to that? Did it, what kind of response did you have? So typically what happens is when someone gets a bone marrow transplant, body undergoes what's called conditioning, chemotherapeutic conditioning, okay? So the first 2 weeks. And then in those first 2 weeks, you can see a lot of ulcers in a patient's mouth, okay? But that's okay. Usually those go away after 2 weeks' time, and then, they get back to normal, okay? But occasionally what happens is that process extends for a longer period of time. Okay, so you can see these changes even beyond 2 weeks after the conditioning period. Okay, so when you see those changes beyond the 2 weeks, but if it's less than 100 days, you call it an acute form of GVHD or graft versus host disease. Okay, but if it's beyond 100 days, then you call it a chronic form of GVHD. That 100 days number is very arbitrary. Okay, They just came up with that number, and then they said anything below 100 is an acute form, and if it's over 100 days, it's a chronic form. Yes?
How can you tell the difference between this and lichenoid contact stomatitis? Because
History.
okay.
So lichenoid contact stomatitis, patients will not have a bone marrow transplant, a history of that, right? So if they have a history of a prior malignant disease, and if they were treated with a transplant, then you're going to consider this more likely to align with a GVHD. But if they didn't have that, then you have to think of other things that can present as lichenoid lesions. Okay, so history is extremely important for all of these things. So basically, the acute form of the disease affects about 50% of the patients, and then they also have skin lesions apart from oral lesions in patients with acute GVHD. And then the skin lesions can actually look like toxic epidermal necrolysis. So they have this diffuse sloughing apart from oral lesions. In the chronic form of the disease, so this is a chronic GVHD, what you're seeing here, examples. The oral lesions are the ones that actually mimic lichen planus. And they can also have skin lesions that can mimic lichen planus, or there's another disease called scleroderma, or systemic sclerosis. Okay, so things to remember is if you have a patient with a history of a bone marrow transplant, and then you see lesions that look lichenoid in a patient's mouth, you have to suspect that this is graft versus host disease. And there are two different types of graft versus host disease. You have an acute form and you have a chronic form. An acute form typically is if it's less than 100 days, of the transplant. If it's more than 100 days after the transplant, then you consider it a chronic form of the disease. Okay? The acute form can have oral lesions and skin lesions, and the skin lesions are very similar to toxic epidermal necrolysis, so you have the scalded appearance of the skin. The chronic form, it mimics more of the lichen planus. Okay, so the lesions that you see tend to mimic lichen planus. Again, this is not something that we end up treating if you have a patient like this. If they do have oral lesions, we can treat them with topical steroids, but you have to refer them to a physician, to address the underlying concerns. Okay, and then you have to eliminate any potential source of infection. These patients can also have an increased risk of caries because they tend to be xerostomic. Okay, so they have dry mouth, so you have to put them on topical fluorides. Okay, so basically, we had pemphigus vulgaris, mucous membrane pemphigoid, lichen planus, all three of them with desquamative gingivitis presentation. Then we talked about graft versus host disease and lichen planus having similar oral presentation, oral lesions. And then there's another condition called systemic lupus erythematosus. Are you guys familiar with lupus? Okay, so there's three different types of lupus. You have systemic, you have chronic cutaneous, and if you have subacute. Okay, the one that we encounter more commonly is the systemic or the chronic cutaneous because they both have skin and oral lesions. Okay, this is a pretty common disease. It affects about 1.5 million people. This is considered the most common connective tissue disease in this country. Okay, it's again immune mediated, and there's different theories behind why you see this condition. Basically, what you see here is this increased in the activity of B lymphocytes, along with an abnormally functioning T lymphocytes, is basically the main reason why you see this. Okay, so lupus, and these examples are from your textbook. I don't have really good ones in my collection, but what I wanted to show you is the characteristic presentation that you see here with lupus patients. What do you guys see here that's typical of, you think, lupus?
Those red lesions.
Those red lesions, right? Where do you see the red lesions? On the cheeks, okay? But do you see any lesion on the top of the nose? Yes. But do you see anything on the side of the nose? Near the ala of the nose? No. It usually spares this fold right here. So it looks like a butterfly. So this is called a butterfly rash. When you see this kind of a rash on the skin of the face, you have to think of systemic lupus. You can also see that in chronic cutaneous lupus. So the whole lupus erythematosus can have this butterfly skin rash. Okay, so the way it presents is you'll have these red lesions on either side of the cheek. You'll have involvement of the top of the nose, but it actually spares the nasolabial folds, so the sides of the nose. Okay, is usually spared. So systemic lupus, as the name suggests, it's systemic, right? So that means it not only affects the skin, it not only affects the oral cavity, it also affects other organs. So it tends to affect the heart, okay? It tends to affect kidney. A lot of times patients actually die from kidney disease in patients with lupus. Okay, so death is commonly because of kidney disease. And then the skin lesions, when they're exposed to sun, okay, it actually worsens this rash that you see on the skin. Okay, and about 40 to 50% of the patients actually with systemic lupus actually end up getting the skin rash that's in the shape of a butterfly. It's a disease that affects younger patient population. The average age is actually 30 years approximately. Okay, so remember the other ones that we talked about were more adults, right? Middle-aged adults, women. But this one tends to be women, but more younger. Okay, and then these patients can also have dry mouth. They can have periodontal disease. They can have excessive gingival bleeding. So there's other things that could be of relevance, when you're seeing these patients with regards to the oral cavity. But what do you guys see here? That's okay. You have what looks like a red and white lesion, but where's the red? In the center. Okay. Where's the white? On the periphery, right? And then if you saw this kind of a presentation with a central redness and then surrounded by these radiating striations at the periphery, what was the one thing you would consider on the top of your differential? Erosive lichen planus, right? This is what it looks like. But this one is actually a patient with lupus. So patients with lupus can actually have oral lesions that can mimic lichen planus. Okay, so this is another entity that can mimic lichen planus. So there were three things so far that we said that can mimic lichen planus, the erosive type. One was lichen planus itself. Then you have GVHD, graft versus host disease, and then you have the systemic lupus. Okay, can have this presentation. And then we also talked about reticular type of lichen planus is being mimicking a lichenoid reaction, secondary to amalgam. Okay, so this is an example of chronic cutaneous. Okay, again, you get these significant erosive areas, and then you have these white striations around. You can have involvement of the palatal mucosa, but then on the skin, it gets these really white plaque-like appearance. Okay, so this is something you tend to see in the chronic cutaneous type. So basically, they start off as these red patches in areas that are exposed to sun, and then what happens is eventually they scar, and then they show either increased pigmentation or decreased pigmentation in that area. Okay, so that kind of pattern, it's called discoid lupus erythematosus. So chronic cutaneous lupus, when they have skin lesions, they can start off as these areas that are ulcerated, and then eventually become hypo or hyperpigmented. Okay. And they can also have butterfly skin rash. So in patients with lupus, the critical thing is, again, this is not something that you diagnose. For these patients, you may see oral lesions. We recommend that they get a biopsy done, right? And then once you get a diagnosis back on the biopsy, you have to send them to a physician for treatment. Because with systemic lupus especially, there's involvement of other organs. So it's beyond our scope of practice with treating these conditions. So what you have to do is whenever you see a patient with lupus, what the physicians do is they do a blood test. Okay, and then they look for certain antibodies in the serum. Okay, so these are the three antibodies that they look for. Anti-nuclear antibodies, anti-double-stranded DNA antibodies, and anti-Smith antibody, SM. Okay. So anti-nuclear antibodies are 95% of patients with lupus actually have the ANA, these antibodies. Okay, and then 70% of the patients with lupus will have positive for this anti-double-stranded DNA. And then anti-Smith antibodies is only positive in about 30%. So with lupus, remember there's three different types. You have the systemic, chronic cutaneous, and you have subacute. Systemic is the one that has involvement of skin, mucosa, and other organ systems. And patients, when they die from the disease in systemic, it's usually because of kidney involvement. They can have involvement of heart. And then systemic lupus and chronic cutaneous lupus both have the butterfly skin rash. Okay, and they both can have oral lesions, and the oral lesions in systemic lupus especially mimic the erosive lichen planus. The same thing can happen in chronic cutaneous, but that's not as common as systemic lupus. So systemic lupus is the more common one among 3 subtypes. So, and you also, treatment-wise, you have to advise the patients to avoid, sunlight. So they wear like a wide brim hat. They use a sunscreen. You protect the skin as much as possible, because with exposure to sun, they can get this skin rash on their body, right? So if it's how do they treat lupus? So typically, if it's a milder form of the disease, they treat it with an anti-malarial drug. Okay, but if it's a severe form of the disease, then they may put them on systemic steroids, and then they use other immune suppressive drugs to treat it. Okay, and then the oral lesions, you can just do topical steroids, but they're not as effective, the topical steroids. Typically, as I said, this is something that you have to refer to a physician for them to, initiate treatment, because there's involvement of other structures. The 5-year survival rate for lupus, systemic lupus, is about 95%. But if you look at 20-year survival, it drops. Okay, so at 20 years after they've been diagnosed with the disease, there's only a 75% chance of surviving this disease. Okay, so it has a potential to kill a patient, and the reason why is because of kidney disease, the renal failure. And especially if for men, if they're diagnosed with the disease, or blacks that are diagnosed with this disease, unfortunately the prognosis is worse. So the mortality rate is higher for those 2 groups. If someone has lupus, it's probably better to get chronic cutaneous lupus rather than systemic lupus, because the prognosis is a little better with chronic cutaneous. Okay, so the next entity that is also considered a connective tissue disease, it's called systemic sclerosis. This is, the other name for it is scleroderma. This is extremely uncommon. The likelihood of you seeing this disease in your practice is pretty limited. I haven't seen one in my practice yet. This is, you get about 10 to 20 people per million that get diagnosed with this disease per year. Okay, but this is also a connective tissue disease. So again, we don't know exactly what's the etiology, but again, this is an immune-mediated disease. But what's unique about this disease is the deposition of collagen. So what happens is, in patients with systemic sclerosis or scleroderma, they have excess collagen that gets deposited throughout their body. Okay, so what do you think happens when you have too much collagen?
Tight.
Exactly. So if you look at their face, again, as I said, I have never seen one in my practice. I've used examples from your textbook. They actually have a really tight skin, okay, to the point where it actually, has the appearance of like a mask, okay. So it's almost like expressionless, the face. Unfortunately, that's because of too much collagen deposition. But what else is going on here? The nose, right? Look at the nose. Does it look kind of pinched at the bottom? So when you look towards the ala of the nose, it almost has a pinched appearance to it, okay? So that is something that you tend to see with these patients. How about the mouth? Does that look like normal mouth opening? No, so that's limited mouth opening, right? Again, because of excess collagen deposition, these patients actually have limited mouth opening. They have microstomia, okay? So again, this would be a problem in maintaining good hygiene for these patients, right? Because they have difficulty opening their mouth completely, and then when they come to the clinician for a cleaning, it's difficult to access these areas because of such a taut appearance of the skin. So this kind of face, they have 2 different descriptions to describe it. One is a mask-like face because of the excess collagen, so it's almost like expressionless, and they have a really smooth, tight skin. And then the other one is called mouse-like face because it pinches the nose on the sides. So you actually have the atrophy of the ala of the nose, the sides of the nose, and it looks really narrow and pinched appearance. So it gives the appearance of a mouse. So it's a mouse-like face. And they have microstomia, And if you look at their lips, basically, if you look at the corners of their lips, they almost get these lines that are kind of radiating from the sides of the lips. It's not very clear in this one, but it's called a purse string appearance when you look at the lips. Okay. The tongue can get really thick because of excess collagen, and it doesn't move as easily for these patients. So it really feels like a thick board when you touch it because of too much collagen. So everything becomes really taut, really firm, and they have difficulty, with movement. Okay. These patients, they also have involvement of their fingers. Okay. So what you see is they can have ulceration at the fingertips. What's happening with the shape of the fingers there? So it has this claw-like appearance, right? So they get this curvature to them, again because of excessive collagen deposition. Okay, and then because they have ulceration at the fingertips, and then when they heal, it starts, affecting the fingers. They actually have a shortening of the fingers because of this, because it constantly happens. It's called acro-osteolysis. When you look at these patients radiographically, they tend to have significant loss of, so if you look at the periodontal ligament, are you guys familiar with reading radiographs? Okay, so you guys know where the PDL is, right? Okay, so does this PDL look widened? Yes. So there's widening of the PDL, but it's not just with one tooth. Look at all the teeth here. So there's diffuse widening of the periodontal ligament space with these patients, again because of excess collagen deposition in this area. Okay. And then occasionally you can get scleroderma that's just localized to this portion of the head. Okay, so it almost looks like someone has been struck with a sword and then it leaves a scar. Okay, so this is called localized scleroderma, and it's just a limited form of scleroderma. So it's a very limited form of this disease process. Okay, this is not life-threatening. Again, these are not patients that we end up seeing in our clinical practice for treatment. You have to send them to a physician. They put them on this penicillamine, which can inhibit this collagen from being produced. So it limits that. And then, but the big problem dentally for these patients is because of poor hygiene, because they have difficulty in mouth opening, they have this thickness of the tongue, so the tongue doesn't move as much. They may have xerostomia, there's dryness in the mouth. They have decreased dexterity, right? Because if you look at their fingers, they have claw-like, positioning of the fingers, so that doesn't, prevents them from maintaining good hygiene. So those are things that you have to consider when you treat these patients. And the prognosis is pretty poor. We're going to look at this last entity. This is something you will encounter in your clinical practice. This is extremely common. Are you guys familiar with geographic tongue? Yeah. So geographic tongue is, a lot of patients have this. Most patients don't even know that they have it unless and until you point out to them, because they're usually asymptomatic, right? There's different terms that are used to describe it. It's called erythema migrans because it's a red lesion that basically migrates, in the mouth, right? Most commonly it affects the tongue. So that's why it's called geographic tongue, but you can see this affect other areas of the mouth other than tongue, okay? Then you use the term erythema migrans to describe that, if you see it in a site other than tongue. It's unknown etiopathogenesis, so we don't know exactly what triggers this, but there's some theory that it could be related to psoriasis. So if a patient has psoriasis on the skin, there is a possibility that they may have geographic tongue in the mouth, okay? Because they both share the same human leukocyte antigen, in studies that they've noticed that. But this is considered an inflammatory condition. So what do we see here? A tongue. Well, the tongue, if you see towards the ventral aspect of the tongue, yeah, so what you see here is this area. It's not really clear, but you have an area that looks red, but then you have an area that looks kind of white. And it's not a straight white border, it's kind of scalloped. Okay? So this is something that's typical of geographic tongue. You get a red area in the center, and you get a whitish border, but it's not striations, that white border. It's basically a thick white border, and it's a scalloped border. And it can be a complete border, or it can be incomplete. Okay, and as I said, it typically is seen on the tongue. It tends to be more common in women. Okay, and this is commonly associated with another condition on the tongue that's called fissured tongue. So you get these grooves on the tongue that are basically considered fissured tongue. Okay, and sometimes you can see geographic tongue in an area of the mouth that's other than tongue. So this is on the buccal mucosa, but the characteristic thing is it's a central red area surrounded by white. Okay, I'm sorry?
It looks like the target one.
Yes, but target one, remember that's this thing that we describe only on the skin. You don't see it in the mouth, target lesions. Erythema multiforme, the target lesions are just localized to the skin. So we just have a couple more pictures and we'll be done. I know you guys have to set up. Here, again, same thing. If you see here, you have these erosive areas and then you have this whitish border around it, and that's a scalloped border. It's not a straight border, so it kind of, has a curvature to it. You don't need to do the biopsy. Again, when you see geographic tongue, please don't biopsy it. Please don't recommend that the patient gets a biopsy done because you should be able to make a diagnosis by just looking at it. And then you let the patients know that if it's not symptomatic, you don't have to treat it. But if they have symptoms like pain or burning sensation and they eat something spicy, acidic, then we can treat them with topical steroids. Okay? But otherwise, this is just something that needs to be noted and made the patient aware of. Okay, we are done. If you guys have any questions about this topic, we can always revisit it on Friday when we have the neoplasia lecture. So the next lecture on Friday, it's actually a general pathology topic. Okay, so it's neoplasia, and that's going to be on your Gen Path section exam.
So Gen Path exam. When is our Gen Path exam? No, it's next week. Is it right if I ask you some questions? Yes.
Well, as far as geographic tongue, migrants, where it would be anywhere else on the tongue.
You can use it even on the tongue. So erythema migrans, either you can use it on the skin, or you can use it elsewhere on the tongue. Because when you say geographic tongue, buccal mucosa, that doesn't make sense.
I see.
So that's why you use the term, more descriptively.
Okay. How would you differentiate those clinical features
Go around
of
the cornea
from the rear after the ulcer?
Okay.
So the lichen is also minor, right? So what is it typically
Okay.
It's the reverse, right? So after salsilla, you should have a white center and a red periphery. Right? Whereas in geographic tongue, it's the other way around. You have a red center with a white scallop.
Really, we should have known that.
That's okay. And it's a good point because they can mimic each other, if you're looking at elsewhere other than the tongue.
And then as regards to lupus, are you born with lupus, or it can happen
Over a period of time because it's an immune-mediated disease. You don't necessarily have to be born with the disease. It's not a genetic disease. It's an immune-mediated disease.
So if someone gets it throughout their life, how soon will the clinical features show a person?
Yeah, so typically it's a small onset. Usually starts off, like the earliest age that we usually tend to diagnose this when the patient has these manifestations is usually late 30s. But it's not something that gets diagnosed sooner than that. But we always have exceptions to it, right? So the common age group is in the 30s that they get diagnosed. But it's something that it's a slowly progressing chronic disease process. But then there is this thing that if you have twins, that there is maybe a higher likelihood of a twin, developing this disease process if another twin has it. Even though it's not a genetic disease, it's not something that you're born with, but there is that risk of, one person has it and there's a likely chance that they may end up having it.
In your experience dealing with lupus, do you see a pattern of one clinical feature such as the butterfly happen first, and then as it progresses you see the other ones? Is it like...
Yeah, so typically the skin rashes are the ones that are more common compared to like oral lesions. So a lot of times that could be your kind of, clue saying that, okay, there may be changes that are going on that could be suggestive, because a lot of times when there are internal changes going on, it doesn't manifest, as quickly as we would like. So the disease could go undiagnosed for a long period of time. So yeah, but if there is a characteristic skin rash, that is something that I would, exactly.
Okay.
Because that's not too many people to present, with that kind of material. So that would be high on the list.
All right. Thank you so much.
No problem.
This for this Friday's quiz, it's gonna be on physical, allergies,
Just those two.
just those two.
Yep.
Okay. And then
Skin
another.
diseases, I think, is the week after.
Okay. And then another question. So for quizzes, do you want us, for example, are you gonna like ask us like the general like lupus or the erythematosus, or are you gonna like also include whether it's systemic, chronic, subacute cutaneous?
Subacute cutaneous is not something I would worry about too much, but you should know the difference between the first two, because that's something that can have, variable manifestations. But the systemic is very different, right, in its presentation because of the degree of involvement of other organs. Whereas with chronic cutaneous, as the name suggests, it's a chronic disease. It's predominantly a skin disease. It's cutaneous, right? But then you can also have oral lesions. So this one predominantly tends to be just skin with some oral lesions. This one tends to be skin, oral, and any other organ system.
So you want us to be descriptive too?
If there is enough information to make you make a definitive diagnosis, yes.
Okay.
But if not, you can say more generic lupus erythematosus.
Okay.
But if there's a specific information that's available that indicates, that you should be specific.
Okay. And then also, will you ask us like if there's treatment or not?
We're not going to go too much into detail with treatment, but you should know at least the common ways that these get treated, just to be aware of the treatment modalities. But we're not going to spend, because that's not something that you need to be too concerned about, especially when you're seeing patients, because the critical thing for you guys is, can you recognize, when you do recognize, do you know the difference between different entities that can look like each other, and how do you advise this patient to move on with the next phase of, whatever needs to be done. So you need to be aware, like, does this patient need a referral? Does this patient need a biopsy? If they're treated, then you need to know, like, the more common basic treatment, not too much in detail.
Okay. And then also, so you're going to include pictures and questions?
Yes. Okay. So typically the pictures get projected on the projector, and then you'll have to write, like, it usually ends up being a short answer. So you have to write in, whatever it's a diagnosis, a differential, or a basic treatment, But the treatment, don't get too, caught up in that with regards to, like, everything. But you need to know the more common ways the disease is treated. Because there's many different things that you can use to treat one thing. But you need to know what's the more common, more likely thing that, the first line of treatment, basically.
Okay.
Something you should know.
All right. Okay, sounds good. Thank you.
No problem.
Fill out the yellow sheet, but I didn't pass it. That's enough. I didn't pass one. Because I didn't review beforehand. I just picked it up and then chose the worst videograph I could find. So I'll find a better one next time.
Well, I'm big enough to have 2 seats. I'm using it all. Sorry, guys.
Downloading a 1 terabyte file?
Yes. How did you know?
Just out. See, I'm smart. Oh, I see. I can't do this anymore. Can we just graduate already?
Senioritis.
Can't wake up in the morning.
I bought like a penny stock just to see, like, it went up like 4 cents. I sold it. It's
Did you follow his message? Yeah. So boring. Religion is boring. Armstrong is boring. This is alright, but it's like, oh.
Yeah, put it in a circle. Take this, you click it on the click on
Oh, really? Yeah. Yesterday, my honey's car broke down. A rental car. I just got it yesterday. The same day. These things that the oil has been changed for a while. And just the engine just go away. I drive at 11 yesterday. We came up. It was like 15 minutes away. Long Wednesday or something like that. Yeah. It was going back. Anyways, yeah, that was fun. So now I have to drive him to LA so he can get it on.
Why does it have to be like
Because that's specific. Yes,
They don't have one here. You know, like how I remember
he does sometimes. I mean, not half of the time.